Hello, and thank you for joining us today for the ACA's Impact on Cancer Care, What's Ahead in 2014. My name is Elizabeth Reed, and I'm the Project Manager of Healthcare Professional Education at the GW Cancer Institute. Before I get started, I wanted to take a few minutes to go over some housekeeping remarks. We ask everyone to keep their phones on mute to avoid any background noise and disruption during the program. Due to the large audience size, we will utilize the Q&A feature for this webinar. You will see the Q&A box at the bottom right hand of your screen. If at any time during the presentation you have a question, please type it in and we will address it during the Q&A portion at the end of the webinar. The questions are anonymous and I will repeat the question. We will take questions at the end of the presentation, but feel free to write questions in the Q&A box as we go, and we will make sure to answer them during the time allotted. To reduce the background noise and enhance communication quality, we will utilize this feature for all questions during the webinar. I would like to take a moment to review today's agenda. Mandy Pratt-Chapman will provide a welcome and overview of the Center for the Advancement of Cancer Survivorship Navigation and Policy, followed by a brief overview of the ACA, and Juliet Forstenser-Espinoza presenting on the impacts of the ACA on cancer care. We will wrap up the webinar with some Q&A from the participants. Reminder that due to the large audience today, we have over 200 of you on the line, we will be taking Q&A through the Q&A feature on your screen. I would like to introduce Mandy Pratt-Chapman. Mandy Pratt-Chapman is the Associate Director of the George Washington University Cancer Institute, responsible for strategically planning and implementing prevention, community health, patient navigation, and survivorship programs, as well as overall fiscal management and development for the Institute. Ms. Pratt-Chapman works with clinicians, researchers, and advocacy stakeholders to improve access and delivery of care to cancer patients and survivors. I will now turn it over to Mandy. Thank you so much, Liz. I wanted to provide you a brief overview of our Center for the Advancement of Cancer Survivorship Navigation and Policy before we get started on today's webinar. Our center, which we affectionately call CA-SNAP, was created in 2009 through a generous grant from the Pfizer Global Health Partnerships Program. The mission of the center is to advance cancer survivorship and patient navigation efforts locally and nationally through education and training, policy analysis, outreach, and research. The center offers survivorship and navigation resources that are available online at our website and through a monthly e-newsletter. Additional material is sent through the CA-SNAP listserv to our over 2,000 subscribers. Our staff write white papers, create case studies, and work cooperatively with other healthcare organizations to advance patient-centered care. We have policy papers on our website to educate patients and the public about the impact of the Affordable Care Act, which I will refer to as the ACA throughout my overview today. And we also share summaries of meetings and roundtables that we've hosted to catalyze patient navigation, cancer survivorship, and patient-centered care initiatives. CA-SNAP is best known for its signature trainings, in particular the executive training on navigation and survivorship. Finding Your Patient Focus historically has been a 2-day training program that equips healthcare professionals with tools needed to launch and sustain navigation and survivorship programs. Through this training, participants learn strategic planning techniques for developing, implementing, evaluating, and sustaining patient navigation and survivorship programs. Since 2010, we've trained over 250 healthcare professionals in live trainings, and we were recently awarded a $2.1 million award from the Centers for Disease Control and Prevention to provide technical assistance and support to comprehensive cancer control programs. As part of this project, we will be transferring our in-person training to an online format that will be available to you at no cost. We will also be developing other new online programs to enhance cancer control activities across the country. Today's webinar is part of the CA-SNAP monthly webinar series, which we launched this past April, and also part of our ongoing technical assistance support for cancer control programs nationally. We feature a variety of topics on our webinar series related to navigation and survivorship based on feedback from healthcare professionals across the country. So if there's a topic that you're interested in, please be sure to let us know. Some of our research initiatives. In 2013, we conducted 2 research studies, Best Practices in Navigation and Survivorship and Healthcare Professional Attitudes Towards Social Media Use. And we used these surveys to inform best practices in healthcare professional education and patient-centered program delivery and presented the results through our webinar series. The archived webinars are available on our website for viewing, and results regarding the best practices in survivorship and education programming will be forthcoming in 2014. We also received funding this year from PCORI, the Patient-Centered Outcomes Research Institute, for a project called Evaluating Cancer Survivorship Care Models. This project is a partnership between the GW Cancer Institute, the GW School of Public Health and Health Services, and the GW Medical Faculty Associates. We also have an advisory board with representatives from the American Cancer Society, Livestrong, the Cancer Support Community, and the Commission on Cancer, as well as survivors, clinicians, and survivorship researchers. The goal of our project is to compare the effectiveness of different models of survivorship care. We have more information about the project on our website in the research section. One other research project that we plan to report the results on and that we wanted to let you know about is our Patient Navigator Competencies Project. We've developed a framework that differentiates different types of navigators focused on community health workers, patient navigators, which are sometimes called lay navigators, and nurse and social work navigators. We will be validating this framework through a national survey of patient navigators to achieve consensus on navigator-specific competencies so we can build a free online training program for patient navigators. We have a variety of research initiatives at GW Cancer Institute, and these enable us to inform our cancer community of progress and provide participation opportunities to you. Our goal is to share the findings so that we can provide you with information to help you provide patient-centered care. And so again, if there's anything that you would like to learn more about or ways that we can address topics of interest to you, please let us know. I'm now pleased to welcome you to the topic for today, our webinar, an ACA overview, the ACA's impact on cancer care, what's ahead in 2014. So today you're going to be hearing from Julia Espinosa about the structure of health reform, key coverage and benefit changes, and known challenges. I'm just going to give you a brief overview of the ACA before Juliet's presentation. So there's been quite a bit of controversy around the Affordable Care Act, and there's been a lot of votes in Congress attempting to repeal the law. Controversy has existed around the requirement to obtain health insurance or face a penalty. Also, in order to provide guaranteed coverage for the seriously ill, costs may be higher for younger, healthier people. There have been complaints about canceled policies for old insurance plans that no longer meet standards of the law, as well as frustration with the online insurance exchange, although the exchange now seems to be functioning much better. Some people are frustrated with new pricing. In order to keep the price of policies down, the deductibles for some policies are much higher than people previously may have had. In general, the price for healthcare insurance is lower and coverage is better for those who previously depended on the private market for individual plans, but costs may be higher for those who have historically had employer-provided plans. In general, group plans have better benefits because the large number of individuals in the plan makes it possible to provide better coverage for a lower cost. Despite the controversy, the ACA clearly benefits the very ill. There have been a number of recent media stories about the impact of the ACA on cancer patients specifically. For example, the New York Times printed an article on December 8th that highlighted Ray Acosta, who was age 57 of Arizona and has chronic leukemia. Ray used to pay $800 a month for premiums plus large co-payments for pharmacotherapy. He now qualifies for Medicaid under expansions afforded by the ACA for low-income adults. Another cancer survivor, Tasha Hubner, age 45, was paying $780 a month for premiums through Blue Cross Blue Shield and had been notified that her costs would go up to $820 a month in 2014. She found a mid-level policy through the exchange for $300 a month. According to the Kaiser Family Foundation, more than 243,000 people have signed up for coverage through the exchanges, and more than 567,000 are now eligible for Medicaid since the exchanges opened on October 1st. This next slide shows some key components of the ACA. Cancer continues to be a leading public health concern, accounting for approximately 1 in 4 deaths in the United States. And in 2013, approximately 1.6 million new cancer cases will be diagnosed in the United States. The ACA aims to help address several problems in our current healthcare system, such as the growing number of individuals without health insurance, the special needs of those who are seriously ill, like cancer patients, and the unsustainably high cost of health care. These are some key ways that the ACA benefits cancer patients, and I'm going to talk to you just briefly about each of them. In terms of access to care, children are now eligible for dependent care coverage up to the age of 26. So this is important for cancer survivors because young survivors sometimes choose to delay care or do not obtain needed care or needed prescriptions due to the cost of care. According to a recent American Cancer Society Cancer Action Network poll, 16% of households impacted by cancer indicated that a pre-existing condition exclusion prevented them from obtaining insurance prior to implementation of the ACA, and 59% indicated they could not afford insurance. The ACA also established temporary high-risk pools through the end of this year, which were put into effect to help insure those who might not be eligible for coverage otherwise. But once the exchanges were put into effect, these high-risk pools should no longer be necessary. The ACA also prohibits pre-existing condition exclusions or loss of coverage when you get sick. So these are really critical components of the law for cancer patients. I'm not going to talk a lot about coverage because I know that Juliet will really focus on this much more in depth. So this is just a really brief overview to give you a taste of what some of the coverage benefits are for the ACA. So in terms of quality, there was recently, just a few weeks ago, there was a new Institute of Medicine report that was issued called Delivering High-Quality Cancer Care, Charting a New Course for a System in Crisis. This report noted that care is often not evidence-based or coordinated, and patients often do not receive adequate education, information, or access to supportive and palliative care services. Arguably, the single biggest challenge to quality cancer care is the existing payment structure that incentivizes volume over quality of services. Cancer patients can pay tens of thousands of dollars for a single course of treatment, and cancer-related drugs represent 23 of the top 55 most expensive drugs for Medicare Part B in 2010. The ACA expands the authority of the Secretary of Health and Human Services and state Medicaid programs to pilot new payment models to elevate quality. New pilot programs include Accountable Care Organizations, or ACOs. These are formal groups of healthcare providers who agree to coordinate care for a certain group of patients. ACOs realign the payment structure to prioritize quality and efficiency of care. While ACOs were originally rolled out through the Centers for Medicare and Medicaid Services, the private sector is increasingly embracing value-based delivery and reimbursement models, with roughly 14% of Americans receiving care from these types of organizations as of February of this year. Another innovative payment model is the Patient-Centered Medical Home, or the PCMH. This is comprised of a health team that provides comprehensive health care and meets standards for performance around disease management, care transitions, and care coordination, quality efficiency and quality data reporting, and the health information technology for economic and clinical health high-tech acts meaningful use requirements. Brandio demonstrated the application of the first PCMH for oncology care. Consultants in medical oncology and hematology, the first National Committee for Quality Assurance designated oncology patient-centered medical home, coordinated all aspects of cancer care through patient navigators, encouraged patient engagement, improved access to care through extended hours and triage services, and used data to continually improve quality of performance as well as patient outcomes. The result was reduced emergency referrals and visits, reduced hospital admissions, improved symptom management and palliative care, and improved adherence to National Comprehensive Cancer Network clinical practice guidelines, as well as overall cost savings. Bundled payment mechanisms are also being studied. Bundled payments include all healthcare services related to a specific course of treatment or condition over a period of time under a single payment. Finally, hospitals are facing more pressure to respond to value-based purchasing, an approach that considers and rewards healthcare value as part of paying for care. Value is typically associated with quality measured by objective benchmarks, and comparative performance information and efficiency also measured by objective standards of performance. Also, as part of the ACA supports research. So the Center for Medicare and Medicaid Innovation, or CMMI, is leading efforts to expand and test payment models mentioned previously. They launched the Pioneer ACO, which is a high-risk, high-reward version of ACOs. They're replicating the oncology patient-centered medical home. They are testing bundled payments for care improvement, through which participating providers receive bundled payments, or one payment for all healthcare services related to an episode of care. And they launched the Financial Alignment Initiative, in which health plans are incentivized to cut expenses by coordinating care for dual eligibles, which are those individuals eligible for both Medicaid and Medicare. As a result of the Center for Medicare and Medicaid Innovation, private payers are also focusing more on value and quality. UnitedHealthcare is piloting a bundled payment initiative and standardizing oncology regimens that are currently highly variable. The plan also pays a case management fee to improve quality of care and patient engagement in decision-making, particularly toward the end of life. Aetna and P4 Healthcare have been working with oncology groups to explore clinical pathway programs or evidence-based regimens to reduce variability in care errors and costs. And finally, Blue Cross introduced a global budget with risk-sharing alternative payment model, which provides prospective payment for anticipated costs of caring for certain populations of patients over a predefined period of time. Also, as part of the ACA, the Patient-Centered Outcomes Research Institute was established. PCORI's mission is really to put patients at the center of research, and their focus is on comparative effectiveness to translate and disseminate research more quickly for the benefit of patients. We are particularly excited about our PCORI-funded study evaluating cancer survivorship care models, which I already mentioned, and through which we are elevating patient-prioritized outcomes to assess the performance of cancer survivorship care at Commission on Cancer accredited institutions across the country. Finally, the ACA does much to support the healthcare and public health workforce. With impending shortages of oncologists, nurses, and primary care providers, the supply of healthcare providers is expected to significantly fall short of demand of patients very soon. There is some disagreement about this. There was a recent op-ed by Scott Gottlieb and Ezekiel Emanuel on December 4th in the New York Times, suggesting that workforce constraints are overstated, and they spelled out how given changes to how disease is treated and innovations in monitoring disease and providing interventions, as well as the increasing responsibility of physician extenders, that the workforce shortage may not be as horrible as it seems. Generally, however, it is agreed that we need to invest in new healthcare and public health practitioners, and the ACA does just that. The law contains dozens of provisions related to healthcare workforce issues, including a national workforce policy development strategy and increasing the supply of primary care physicians, nurses, strengthening the dental health workforce, providing education and training of the workforce, and expanding teaching health centers. Some examples include, for public health and allied health, training, workforce grants, recruitment of minorities into health professions, and loan repayment programs for pediatric allied health practitioners and for those who serve 3 years in the public health shortage areas. Also for nursing, there are workforce grants, there are boosts in Medicare Part B payments for nurse practitioners and clinical nurse specialists, and expansion of nursing student loan programs. For primary care, the ACA funds 300 new primary care residents in 2013 to 2014. It increases Medicaid payments to Medicare rates for some services, and the ACA launched the Comprehensive Primary Care Initiative, through which Medicare will work with commercial and state insurance health plans to offer bonus payments to primary care doctors who better coordinate care for their patients. Finally, there are dental training programs and financial assistance for general dental practitioners and loan repayment for faculty of dental programs, as well as alternative dental health care training to help rural and underserved communities. With that, I am pleased to turn it over to Juliet Forstenser Espinosa. Juliet is the founder and executive director of the Healthcare Rights Initiative, a national nonprofit dedicated to patient education and advocacy. In addition, she's an assistant professor at George Washington School of Public Health and Health Services in the Department of Health Policy. She's a lawyer, a patient advocate, a teacher, and a cancer survivor. She earned her Master's of Law at Georgetown University Law Center in Domestic Health Policy and Patient Rights, and her law degree at the City University of New York School of Law. Juliet also holds a Master's in Gender Studies and Feminist Theory from the New School for Social Research and a Bachelor's in English from the University of Maryland. She's a member of the New York State Bar, and in addition to her advocacy and academic work, she also serves as coordinator of the George Washington University Pro Bono Cancer Legal Project and as a program consultant for the Alliance for Ethical International Recruitment Practices in Washington, D.C. Juliet, I'm pleased to hand this over to you.
Thank you, Mandy. Hi, everyone. It's great to be here. And, the ACA is a rich and deep subject. There's a lot to cover, and we have a limited amount of time. But I put some additional data in the slides that we'll be speaking to specifically just for your reference, and the slides are going to be available afterwards. So just to begin, a lot of things in the ACA are not specific to cancer in their language, but the impact of the provisions in the ACA have profound impact on the ground on cancer care access and on the quality of life of cancer patients. So before the ACA, patients regularly have reported an inability to get insurance because they had a cancer diagnosis in their past. There are pre-existing condition exclusions, both for children and adults. The out-of-pocket costs associated with cancer treatments are well known to be incredibly high, and it's difficult to manage, especially when you're out sick. Even on paper, if you earn a good living, we don't have mandated paid leave in this country, and the Family Medical Leave Act, although it guarantees 12 weeks of leave, is unpaid. There were annual and lifetime dollar limits on our policies, lack of coverage for palliative care and pain management, and in particular, a lack of coverage for aspects of clinical trial participation, and it's well known that that depressed enrollment and utilization of clinical trials. And so we'll talk about the change under the ACA for that, and we're hoping that has a big impact on people's ability to access clinical trials. There's also historically been a lack of coverage for screenings and other preventive measures, and all of that has shifted under the ACA as well. So although the Affordable Care Act addresses all of these things, and I think, Mandy, you did a great job of kind of alluding to this, there are many justifiable criticisms of the approach of the ACA, and now there is disappointment at the rollout of the ACA. But nevertheless, the core components of the ACA that bolster a patient's right to access health care when they have an insurance policy in place, those changes are very real and significant, and they have a profound impact on cancer patients. And for survivors of cancer, in many ways, this is a huge civil rights step forward for people like myself who were petrified of letting their coverage lapse because any recurrence would be considered a pre-existing condition. So the goal of the Affordable Care Act, at its core, is to repair the health insurance market. So nationally, we know there are many, many states in the country where you could have money in hand, but if you were ill or had a history of being ill, you'd be locked out of the market. You couldn't purchase a plan. And people with insurance, and we'll talk a little bit more about this in a few moments, would find themselves seriously ill or a child injured and be going bankrupt. So the insurance wasn't operating the way it was intended. The ACA also, at its heart, wants to expand coverage. They want to fix the insurance market and then expand coverage so that millions of people who don't have health insurance now or have inadequate insurance will be properly covered. And of course, the underlying assumption here, because of the way that the U.S. healthcare system is structured, is that insurance is a proxy. It equals access to care. Now, there's a lot of other issues that would make that point perhaps debatable. Can you find a practitioner? What are the out-of-pocket costs? All sorts of other ancillary issues. But at its core, people who are covered have better access to care and get more care than people who are not. And then these things, the ACA also, and Mandy alluded to this, begins to address the cost and quality issues that are kind of endemic to the current state of our healthcare system, which represents 18% of the GDP, which is why there are so many passionate stakeholders involved in the discussion, in addition to the providers and the patients who are, at the core of the provisioning of healthcare. So one of many consequences of the broken market is that people with insurance can go bankrupt when they get sick. And in the United States, over half, 62% of bankruptcies can be traced back to a health crisis, and a very large percentage, 75% in this study cited here and sometimes higher in other studies, are people who have coverage. And the limitations on their coverage, exclusions, et cetera, out-of-pocket costs, or other insurance market practices leave them exposed financially. And this has a disproportionate impact on cancer patients and other people with very high-cost care. So things that are changing under the Affordable Care Act, and we're going to talk about some of these in more specificity than others, are in private insurance, and Mandy also alluded to some of this. Children can't be denied health coverage if they have a history of illness or are currently sick. Young adults can stay on their parents' policies until they're 26, even if they're married, even if their jobs offer them insurance. There's a prohibition on annual and lifetime caps. And then there's this minimum medical loss ratio, and a lot of people are unaware of this, but no matter what your plan is, and the ratio itself differs, but in general, nationally now, this is a rule that basically says for every dollar that you pay to your insurance company in premiums, a percentage of that dollar, either 80 cents or 85 cents on that dollar, have to be spent on actual care. And money that isn't spent in that ratio on care, if there's a difference, like if your insurance company spends 60 cents on the dollar on your care, they have to refund you those premium dollars. And early on in the ACA rollout, there was a lot of press around that. The ACA also starts to close, although it's a long process, the donut hole under Medicare Part D, and we're going to touch on that briefly. And then it expands coverage and imposes this individual mandate. And we're going to talk in some depth now about the exchanges and Medicaid expansion and what that means. It also imposes a requirement on large employers, generally employers with more than 50 employees, to either provide insurance, or if their employees end up in the exchanges, then they have to pay a penalty. They have to, and it's called the shared responsibility provisions of the ACA. That has been delayed for a year. It was supposed to kick in January, and now it's set to kick in a year from January. So we'll continue to see how the ACA rollout shifts and changes based on issues with all the stakeholders on the ground and political issues. So one of the core things that's been added into insurance coverage in general under the ACA is preventive care. Preventive care has to be covered, and a lot of times you hear people say, oh, preventive care is free, and that always rankles me a little bit because it's not free. You're paying premiums. But preventive care now has to be covered with no out-of-pocket costs, which is significant. So you don't have to pay co-pays, co-insurance, or deductibles for lots of preventive services, which all can be found on the healthcare.gov website. But for cancer patients, this includes a whole range of cancer screenings, smoking cessation, and has a real impact down the road when people have moved from treatment onto surveillance, and then down the road have different kind of preventive health needs than people who haven't had cancer. So the reason that the ACA has focused so much on coverage is because people without coverage still get care, and they get care when it's very late in an illness or things have become emergent, and that care costs more money, and then oftentimes people don't have the resources to pay for those services, so the provider absorbs the cost, and then the cost gets passed on in their agreements with insurance providers, and then all of that gets passed on to consumers. So this cycle of the consumer can't afford the doctor, consumer delays, maybe they have a stage 4 diagnosis instead of a stage 1, or they end up at the ER, the consumer can't pay the bill, the provider shifts the cost to insurers shift the cost to consumers, consumer drops the policy because of the high price because of all of these other elements that would jack up their premiums, or they can't afford the out-of-pocket costs and they don't get care, and then it kind of starts over again. This used to be referred to as the backdoor tax on all of us, even if we were insured, because all of the prices, the cost of all of this uncompensated care, it was being passed on to us in all of these different ways. And the ACA at its core is trying to address this. So very briefly, I just want to give you all, because we're going to talk now about the exchanges, and I think there's been a lot of confusion, and in my opinion, mostly because of insufficient public education about the ACA, about what the exchanges do, and now with some of the controversies Mandy referred to about policies getting canceled and the like, about like what the exchanges even are supposed to do and who they impact. So very briefly, if you look at this slide, I just want to give you a snapshot of how people are covered in the United States. And if you look at the top row, you have people who are, you know, in any private plan, it's like almost 65% of the country, and about 55% of people in the country are covered through their employers. The next number is the number that I want you to pay attention to. It's about 10%, it shifts around, of this direct purchase market. These are people who buy insurance on the individual market, or they work for small businesses, and those small businesses have to buy insurance and utilize what's called medical underwriting, where like the 5 people who work in the bakery all have to submit their health histories, and that's how the premiums for that workplace are set. So these are the things that have been eradicated by the ACA, this medical underwriting and this ability to be basically in a risk pool of 1, where I can be told because I had cancer that I will never be given care if I live in the wrong state because I'm too much of a risk for that insurance company. So the purpose of the exchanges is to pool this risk, and that is the whole underlying premise. Get everybody into the risk pool. That's the purpose of the mandate. And then it creates this social contract, which also has some controversy attached to it, where I might not be sick today, but one day I'll be sick. And maybe today my mother is sick, or maybe today my child's sick. And all of us are in the pool and paying into the pool. And when we get sick, or the people we love get sick, there's a way for everyone to access that care. And hopefully everyone pays lower costs for the care they need and lower costs in this backdoor way for care, because it's no longer uncompensated. So the focus of this direct purchase population, it's 10%, and it can fluctuate, of the population. That's who the 10% of the direct purchase market, and then the uninsured, which is down at the bottom here, this 15%. Those are the people that the exchanges are primarily focused on, those who are uninsured and can't access the market now, and those who have existing plans in this direct purchase market. So all insurance historically, and this is kind of, you know, I'm a lawyer and a health policy person, so I find this stuff fascinating. This is when a lot of people fall asleep. But all insurance has traditionally been regulated at the state level. And when you read the Supreme Court case, if you're interested in that on the ACA, or any of the controversy in the court cases that are still moving through the system, there's a lot of discussion of this, because in our country we don't like for the federal government to take state power away. And in essence, some of this regulatory power has now been taken back on by the central federal government. So, but historically, insurance has been regulated at the state level, and the ACA is crafted in a way that tries to retain that model and give as much latitude to the states as possible. And then there's a federal and state split for the management and the regulation of employer-based insurance and Medicaid. And it's these rules for this direct purchase market that are problematic, and they're different in every state. And in some states, there really are very few protections for people who have this coverage, which is traditionally less robust coverage for more money. And there are kind of known abuses in this market, like cancellation of policies. The other thing I want to call out very briefly on this next slide is the the age range of people who are uninsured. And this is why there's been such a focus on will young people go into the exchanges and purchase insurance, because there's between the ages of 19 and 25 that represent about 30% of the uninsured. And they're really necessary to make the risk pools strong. So what are these exchanges? What are they? And now they're being referred to as marketplaces, which is a little more intuitive. They are intended as a way for people to purchase insurance, and they can only sell what are called qualified health plans, which have there's a whole host of requirements that would make a health plan a QHP or a qualified health plan. And one of those requirements is that every plan that's sold in any of the exchanges, and there's one in every single state, it has to cover these essential health benefits. So very quickly, there are three models operating right now in the country for these exchanges. There's states that decided to do exchanges on their own, and those are state-based exchanges. There are partnership exchanges where states didn't feel ready to do an exchange entirely but wanted to participate in the running of the exchange, and these are the state partnership exchanges or marketplaces. And then there are the federally facilitated exchanges where states are not running their own exchanges and the federal government has stepped in. And if you look at this map, it's a very large number of states that opted, at least initially, not to start an exchange or a marketplace. It's all of the light blue. So part of what's happening is, and what has happened in the implementation of the ACA, was this real hope on the part of the federal government that more states would have taken up the running of their own exchanges. And so, and they haven't. And many believe that over time, there are a whole host of states that have indicated they will once they kind of see how other states, like model states like California and New York, get off the ground and the kinds of problems they have. And once some of those things shake out, there's anticipation that more states will take on their own exchanges. And some of the states just have, political opposition to participating in the ACA at all and have opted against. So very quickly, the 10 essential health benefits are listed here. And one of the things that I generally call out when talking about cancer in the ACA is that lots of things are covered here, but, there was a huge debate and discussion when the rules were passed about fertility as one of many examples that aren't covered. Alternative care like acupuncture and things that are known a need and of great use to people who are going through cancer are not guaranteed covered. That doesn't mean that there aren't plans in the exchanges that cover those things. They just don't have to cover them. So that's important to know. I mean, it's worth shopping and looking at the plans in the exchanges. Also, there are new rules about setting premiums, and this is a huge deal for people who had cancer. So traditionally, insurance companies were allowed to set premiums based on health status and your use of your health care, kind of like if you were to get in a car accident, your car insurance would go up. So if you went to the doctor and needed a lot of services, your premiums would go up. And they were allowed to charge more for women. And that was based on the fact that women could get pregnant, but they didn't seem to alter it. They never altered it if you were either out of childbearing years or could prove that you were infertile. They still charged you more. So these things have changed under the ACA. Now there's a limited number of ways in which the premiums can be different for different people. Clearly it can be different if it's just me covered or if it's me and my husband and my child. What geographic area I live in, because the cost of care is different from region to region, how old I am, but there's limits on the variation in range for age, and then whether I smoke. And that's it. That's the only, these are the only elements that are allowed to be utilized for setting premiums. There's also, all of the benefits are generally the same in exchange plans in terms of these core 10 essential benefits. They all have to be covered in some way for every plan in the exchange, although the plans might differ in other ways. There's these core floor of benefits. What's mainly different in the exchange plans are what your out-of-pocket exposure will be, and that's what is called the actuarial value of a plan. So plans that cover 60 cents on the dollar for every service that you need, every covered service that you need, every service covered by your insurance plan that you utilize that pays 60 cents on the dollar is a bronze plan, 70 cents on the dollar is a silver 80% gold, and 90% platinum. And so, um, and then qualified individuals and businesses can get premium payment assistance, and this is talked about a lot. You can get tax credits for your for premiums for family and individual plans, and tax credits for covering your employees in a small business. And then for qualified individuals, you can get cost-sharing assistance. That's help with your coinsurance, your deductible, your copays, and we're going to look really quickly at what that means. So all of this is done based on the federal poverty level, which sometimes also throws people for a loop. So the tax credits are available for individuals and families if you earn between 100 and 400% of what is called FPL. And then the cost sharing is 100 to 250% of FPL. And if you look at this chart, a family of 3 earning $78,000 can still get help paying for their insurance. So there's a lot of assistance out there for premiums. And then for people below around 250 of the FPL, when the households earn less than that, they can get help with these sometimes prohibitive out-of-pocket costs that prevent people from going to the doctor because they don't have the extra income. And so this is just a chart that you can use if you download the PowerPoint that kind of shows you how some of this works. It caps the premium cost out of your total income, and that's the amount of help you'll get in terms of the tax credit, which will be paid directly to the insurance company. And then for cost sharing, it basically makes the value of your insurance go up and what you have to pay out of pocket go down. So this is just a quick nod to the fact that a lot of people don't know anything about this out in the world, and that should not surprise you as providers and people who work with patients. It's an astonishing number of people, even as late as August, who knew nothing at all about exchanges or what they did. So what's connected and intersects with the exchanges is this Medicaid expansion that Mandy referenced. So very briefly, the federal government is going to cover the majority of this new Medicaid expansion. But the Medicaid expansion itself is not uniform. Many states are opting not to expand, and they were allowed to do this based on the Supreme Court decision, which gave states the option to opt out of expanding Medicaid and still retain their ability to participate in Medicaid as it currently exists in their state. The Medicaid ACA revisions also do something called creating no wrong door. So a person has to be able to go to the exchange, and if it turns out that really they're eligible for Medicaid, the exchanges have to sign them up for Medicaid, and vice versa. If you end up going to sign up for Medicaid and really you're eligible for the exchange, the way the system is supposed to work is you're supposed to be signed up no matter for whichever one you're eligible for, not kind of turned away and sent down the street. The Medicaid expansion is really important for many cancer patients because they can't afford insurance, even with assistance, and they don't qualify for Medicaid in their state, or they didn't prior to this expansion. So this is a kind of key to health reform was, okay, we're going to expand Medicaid, we're going to open these exchanges, and that together with employer-sponsored coverage, we're going to end up with universal coverage. And that was the intention. But because of the limits on the expansion, the orange states here are not moving forward at this time. That's 23 states that are not moving forward. So the access to care in these states for cancer patients who are low income is going to be far different than in the states that expand. And this is just a quick snapshot to show you kind of the radical difference. The Medicaid expansion under the ACA allows adults, no matter what, whether they're married, whether they have kids, whether they have a disability, if they earn below 138% of the federal poverty line, to get Medicaid. That's what the expansion does. And without it, on average in states that aren't expanding, the earning cap is 48% of the federal poverty line, which is a very, very low income, and it's really only for parents of children and those who are disabled or pregnant. So that's the Medicaid expansion, and all of these things are worth kind of looking at a little more closely. There's a lot of resources on the GW site and in general about this stuff. So I quickly also wanted to call your attention to the Medicare Part D donut hole discussion, and some people I know aren't clear on what this is, although most providers are. And in short, Medicare Part D, which is the drug coverage portion of Medicare, which is for folks 65 or older, or people who have been ruled disabled and have been disabled for 2 years or more, according to the Social Security Administration. Those Medicare beneficiaries, this drug plan had a gap where if you hit a certain number of out-of-pocket costs for and insurer costs for your prescriptions, your coverage just cuts off. And initially, you pay 25%, and then along with your premium, and the plan pays 75%. And and these numbers have gone up as years have passed. But when you hit about $3,000, all of the costs of your drugs you become responsible for. And this has had all sorts of well-known repercussions for people who are on any kind of maintenance drug, including cancer patients who might not be on a maintenance chemo drug, but might be on something that's a direct result of the fact that they had cancer, long-term cancer health effects. They might be on drugs that they need that they fall into this donut hole. And then they have to spend another huge chunk of money out of their pocket within that calendar year to close it. So the ACA starts to close it. It gives some money, I guess a little bit every year. They started, the first year was $250 to close it, which is very little compared to the thousands of dollars. But over time, this is expected to close significantly, which is important for Medicare beneficiaries. The other big issue that I've talked a lot about with folks, even though the provision is simple, it has far-reaching implications, is the clinical trial coverage. And prior to the ACA, a lot of people were being told that, if they went into a clinical trial, they wouldn't be able to utilize any of their other services paid for under their plan, and that if they had anything that the insurance company could deem connected to the clinical trial would not be covered. And many of these were routine patient care costs. So all of the provisions under the ACA do not allow that. So beginning January 1 of this coming year, you cannot limit or drop coverage for people participating in trials. Plans have to pay routine patient care costs. And coverage extends to clinical trials conducted outside of your state, because as you all know, oftentimes you end up going to a research center in a different location from where you live, because that's where the trial that you need is happening. And cancer doesn't care that you live in Utah and the trial you need is in Massachusetts. So they're not allowed to do that, although you still have to be very careful about in-network and out-of-network. And a lot of plans don't have any out-of-network coverage, and this doesn't mandate out-of-network coverage. So when I counsel patients about what plan to purchase, when we talk about that stuff, often we talk about the need to have a little more flexibility than a plan that has no out-of-network coverage in case that's required down the road. So we've talked a lot about a lot of different provisions, and I know we moved pretty quickly, and I want to leave time for questions. The ACA is significant for cancer patients and for the providers and for their caregivers and their network of support. It expands access to health insurance coverage, which is expanded access to care when you're diagnosed, and it makes health insurance much easier to understand. There are all of these new rules about how your benefits need to be kind of displayed and described to you, and you're going to start seeing that both in exchange plans and outside of exchange plans in terms of how your benefits read. It's not going to be this like crazy contract you can't discern. It has to be very clear, and those rules are kicking in. There are new, stronger appeal rights for when your care is denied that a lot of people don't know much about, and if you're interested in that, you should feel free to contact me. It's kind of my area of expertise. Your coverage won't run out in the year or in your lifetime just because you were diagnosed with an illness that is expensive to treat. And there are new affordable options for young professionals, like under 26, but also for retirees who, many of whom, had exorbitant pricing of plans between, the age of 60 and 65 if they wanted to retire, and now there's affordable options. As we've said a few times, but it bears repeating, this January is when you cannot be denied coverage due to a pre-existing condition, which for so many of us is like getting out of jail. I mean, it's just such a huge step forward, and it removes such an element of fear and panic and anxiety for people. You can't be charged more because you were once sick and kind of had the audacity to survive, and now you have this health history, and you can't be denied coverage because you become sick. your care won't suddenly be terminated because you hit some dollar amount for drugs you didn't even know the cost of, and you'll never have to choose between saving your life or the life of someone you love and your life savings or your house or your kid's college fund because care is unaffordable. At least that's the goal. That is the goal, and we're all kind of anxiously awaiting to see. So thank you. I know we went very quickly, and I'm hoping that I can answer some questions.
Thank you, Juliet. That was a wonderful presentation. So we had a lot of questions come through during the presentation. So I'm going to read the question and then over to you to respond. And then if we need to follow up, as you mentioned, we can contact Juliet's contact information is on the screen as well. So the first question we had was about does the pre-existing condition non-exclusion rule apply to secondary insurance and supplemental insurance? There was an instance where a patient was denied for supplemental insurance because of her cancer diagnosis.
That's a great question. As far as I know, it is for every plan as of January 1, and if they were applying for coverage starting January 1, that sounds improper to me. If it was prior to this January, then this provision of the rule was not in place yet. It starts at the same moment as the mandate starts because people are afraid. The policy fear, right, is that without the mandate, everyone will wait till they get sick and then buy insurance the day they get sick. So, but yes, for supplemental insurance, things like Medigap, retiree plans, yeah, it's the same rule should apply uniformly.
Great. Thank you, Juliet. We have a question about what is available to patients in states that have not chosen to implement the Medicaid expansion. And then further on. Okay, I'll let you take that.
Well, sure. Well, I mean, that's a really interesting question, actually, and there's been a lot of discussion and debate around this. But right now, for states that aren't expanding Medicaid, in the exchanges, their eligibility for premium assistance begins at 100% of the poverty line, which is a lower level of eligibility. It's normally under the expansion, it would be 139% is the magic number where you can get premium cost-sharing assistance through the exchanges. And so what they've done as a workaround is they've said in states that don't expand, you can now get into the exchanges and get some help at 100% of the poverty line or above. But look at what that does, right? In a state where Medicaid eligibility might be 68% of the federal poverty line, right? It's the people with the lowest income and the least resources between the Medicaid eligibility for some people will go up to 68%, and then there's a 68% to 100 gap, plus all of the single adult, unmarried, childless people who have few options, and that's part of the crisis of that's trying to be addressed. So it is a serious problem. Go ahead. All I was going to say is the one fix that we know of is this 100%, like the lowering of the doorway in those states into the exchange. Just not enough.
So there's a few questions coming in regarding the ACA's coverage of preventive cancer screenings versus diagnostics,
right.
And that the ACA does not cover diagnostics, and will that ever change in the future of the ACA implementation, or if you can talk to that a little bit?
Well, I mean, that's interesting, and I don't think it doesn't have a straightforward answer because arguably the ACA does say that laboratory testing has to be covered to a certain extent, and in some cases that is diagnostic testing. But if you're talking about many plans, when you look at the basic like outpatient function, cover some imaging, but there is no blanket requirement for all diagnostic testing. That's true. So a lot of the screenings that have been included at the moment, they do not assist if you have a high out-of-pocket cost and your doctor wants you to get some kind of imaging done. But in theory, if there's lab work, diagnostic lab work, you should have some benefit for that. But diagnostics is another issue where, for some people, most people will have the benefit, but it could be a costly benefit. And then the people who qualify for cost-sharing assistance, will get some, but the people who don't will be saddled with that, will continue to be saddled with that cost.
So we have a few questions as well about the states not choosing to expand its Medicaid program. So the question is, if you do not have income, do you qualify to participate in the exchanges?
Interesting. Well, I mean, for Medicaid, if you don't have any income whatsoever, you generally are going to be Medicaid eligible. And if you're over 65 and you have no income, you're going to be kind of dually eligible for Medicare and Medicaid. So someone with no income, I don't think would be eligible. The gateway in those states is, this dollar amount, this arbitrary dollar amount of 100% of FPL, which and we can check and see. I can take a quick look while we're talking about what that number is. But yeah, I mean, I think the answer for people with no income is Medicaid, and then states that don't expand, they'll have, if they don't fit into one of the categorical eligibility requirements, then I mean, they're going to have some trouble getting access to coverage.
Yeah. These are kind of coming in rapid fire, Juliet.
Sure.
So you have a question about, is the cost sharing only for patients who obtain insurance through the exchange, or is it available to patients who have high cost insurance available to them through their employment?
That is an amazing question, and I'm glad someone asked it. No, it is not available to people. This cost-sharing help is not available if you get your insurance through your job. But what I will say, and it's important to note, is that if your insurance costs more than, I think it's 9.5% of your wages in your job, and there's a whole test for this. If your insurance costs you more than that percentage of your income through your employer, that gives you the right to go into the exchange. And also your coverage has to have an actuarial value that's on the dollar 60% on the dollar actuarial coverage for covered benefits in your plan, and it can't cost you more than 9.5% of your income for your insurance through your job. And if it does cost more than that, you get to go into the exchange, and then you do have access to the cost sharing. The one other caveat about that I should say, though, is that 9.5% calculation, if you get your insurance through your job, it doesn't include if the cost of a dependent or a spouse, so that I can't total up what I pay for me and my family, and if that's, which is more than 9.5%, and get into the exchange. I only can look at the amount for me as an individual. But it's a great question. And,
I'm going to try and sneak in a few more questions since
sure.
we have a lot. So another question is, what is meant by the grandfathered health plans that will not be required to comply with the coverage of SOC services due to clinical trial participation?
Right. So grandfather plans, and this was a little too thorny to go too in depth to today, and I'm happy to answer questions about it. Basically, there's a provision that says a plan that is grandfathered is a plan that was in effect the day that the ACA was passed, which I think was March 23rd, 2010. And if it was in effect that day, it's grandfathered. But you can lose your grandfathered status by changing the benefits in any fundamental way, changing a category of covered benefit or hiking up the cost of the benefits over a certain percentage. So the vast majority of grandfathered plans we don't believe will remain grandfathered, but those that are grandfathered now, they're not subject to a huge number of these provisions, and it's really confusing. But that's what these grandfathered plans also have to announce very loudly to you that they're a grandfathered plan in all of the paperwork they send you. So, and you have the right to verify that they're grandfathered, but that's what a grandfathered plan is. So hopefully that's helpful. And that's a confusing subject, and I'm happy to answer any questions about that. You can email me.
So we have two similar questions regarding patients who go and have a colonoscopy, have a screening colonoscopy and discover polyps. Is the colonoscopy still covered as a screening colonoscopy, or does it change to a diagnostic colonoscopy?
I think, yeah, and I think that's an interesting question. I don't think they can switch it. Like, because you got diagnosed because of a colonoscopy during a screening, it's still a screening. I think it becomes diagnostic. If they're trying to get a visual on some, they know you're sick already, and then they're trying to get a visual, or they're trying to do a follow-up if for surveillance later. There's like a distinction between diagnosis and surveillance. I will say, though, that depending on the plan, the preventive colon cancer screening isn't always a colonoscopy. Sometimes it's like a fecal blood test or something. So you just, again, you want to know what your plan says about that. And that seems to differ region to region in the country.
Thank you. And so there's a question about if the state is not expanding Medicaid, if people are able to participate in the exchanges.
Yeah, and again, it's this 100% cutoff in the states that aren't expanding, which is, and I just checked, for an individual, it's about $11,500 is 100% of the FPL. So if you earn that or more, or $19,500 for a family of 3, then in those states you can participate in the exchanges. But strangely, if you earn less than that, you cannot participate in the exchanges. It was just because the statute was written to interlock the Medicaid expansion with the exchanges, and the Supreme Court decision kind of punched a hole in the middle of it, and that's what those are the consequences we're looking at right now.
I got 3 more questions for
Sure.
those who want to stay on. Can you talk a little bit more about the cost shift from cancer prevention screening to treatment and surveillance?
Well, the cost shift?
From cancer prevention screening to treatment to surveillance.
I'm not exactly sure what you mean by cost shift. I guess when, the big deal about prevention in the first place is that insurance plans historically didn't invest in prevention because they had no guarantee that you would still be a beneficiary of one of their plans down the road. So that's where and so people didn't get preventive care because of that. And so the ACA tries to address that. The kind of access to care once you're ill is kind of in a different policy bucket, and all this, the no annual limits and the no lifetime limits and the access to inpatient and outpatient care and a certain amount of laboratory care and a certain amount of pharmaceutical care, all under the essential health benefits. Those are the things meant to address the costs associated with actual illness and treatment. And if that didn't answer the person's questions, they should absolutely feel free to email me.
So our last question we'll have is, how can cancer patients get additional assistance for copays and deductibles if they can't afford based on their plan, such as a bronze plan?
Yeah, I mean, for the direct advocacy work I do, a lot of times, we look for help from the actual treating institution if they have any kind of, whether it's a charity care program. A lot of them have just out-of-pocket assistance programs. There are a lot of cancer advocacy organizations that give limited grants. I know there are some for adolescent young adult cancers, like the SAM Fund and a few others. But there is no kind of, and some states have programs, but you'd have to look in particular at those states. But it's a huge problem because the out-of-pocket costs can be, paralyzing for people. And there is not a universal fix in the ACA for that at all. And it's going to continue to be an issue that we need to look at and address.
Thank you, Juliet. And thank you, everyone, for staying on the line for a few more minutes. I know this is a hot topic. So I just wanted to mention a few GWCI CA SNAP resources. Please check out our website that includes information on GWCI, CA SNAP, and some ACA initiatives that Juliet mentioned and that were discussed on today's webinar. So this is our last webinar of 2013, and we will start back up again in January with a new calendar year of monthly webinars. And following this webinar, you will receive an email with the recording evaluation survey to provide feedback on today's webinars and today's slides. We will also provide you with Juliet's contact information so you can contact her with any additional questions that you have. She'd be more than happy to answer them. And so I thank Mandy and Juliet and all of you for joining us today, and we hope you have a pleasant day and happy holidays. You may disconnect at this time. Thank you.